talk is loaded. I request the chairpersons to take over the session and start it.
Good morning, ladies and gentlemen. It's a great pleasure to welcome my dear friend, Dr. P.P. Mohanan. All of you know about Dr. P.P. Mohanan and his work. And he is going to talk to us on what are the topic? He is going to talk to about preserving and promoting cardiovascular health in young Indians. You all know that India is a very young country. Nearly 60% or a little more are less than 30 years. So, but there is a growing concern about the health of these young Indians because we are facing this premature atherosclerotic cardiovascular disease in our country, which is a matter of great concern. Unless we take care of this, it is going to cripple the economy of our country. So he's going to tell us about the present and future and need for a volley of actions. And he's going to give us a clinician's perspective. Dr. P.P. Mohanan, it's a great pleasure to welcome you, sir.
The trustees of the Karnataka Cardiology Academy, thanks for having me. It's always a pleasure and privilege to be amongst your seniors and friends. I had fond memories of having coming here from early 90s till about maybe 10 years ago and have fantastic interaction with many of you. I was just trying to, I was trying to find out the etymology of C. Karnataka from the K. Karnataka. And found out that the K. Karnataka was something from 1973, the Vijayanagara Empire. Actually, there is a mention of C. Karnataka, Carnatic in fact, sometime in the 18th century when it was part of the Deccan coastal area. But that is interesting. Well, whenever a sudden death happens especially in the younger age group, the society erupts, understandably so. And especially when the sudden death happens for a celebrity, everybody starts talking, oh, come on, we are seeing all MIs that we are seeing are under 30, under 35. So, I mean, maybe it's partly the cardiologists are also at fault. Just try to look at what is exactly happening in there. Where is the young MI happening? I'm not forgetting. I do remember Jayadeva, Ravindranath, and Jayadeva's data of 5,000 young MI. But then there was a single center, this thing. I'm not forgetting that. But this also happened. I think Ravindranath, the Hassan episode of 1819 sudden deaths, we know about that. But this has been happening for the last many decades. There was again a lot of excitement when COVID death happened, MI in the younger age group. But we know that many of them has underlying risk factors. If you look at the CREATE registry, you could see that the percentage of MIs less than 50. It's not remarkable. The same was for the Kerala ACS registry. You are pretty good. You look at Karnataka. Huh? The age standardized, this is the world GBD data, recent data, where I was also part to the Dendona, with Professor Dendona. this also shows that, I mean, it is definitely the global burden disease data has shown us in 2021 we have 20.15 million deaths due to cardiovascular disease. It was 12 million in 1990. So naturally, as we progress, as we age, the coronary artery disease is going to happen. But there is nothing alarming. Right? This is the NFHS, National Family Heart Survey, and not very old, much later than the creating the Kerala SCS registry. Of course, they looked at different things. You look at that. Now, it is the prevalence rate of coronary artery disease in the young is still acceptable. It is something similar to whatever we are seeing in the globe. So there is nothing to be very much excited. Of course, we are all concerned about the increasing. This is the prevalence rate of coronary artery disease in the National Family Survey, which is I mean, of course, these are self-reported heart disease. There could be some authenticity problems, and world over, this is what is happening. No, there is nothing very special happening in our country. So don't be under the misguided impression that we are seeing very many any MI. Naturally, see, you look at 66% of Indian population are less than 50 or 40, and those in 15-35 age is something like 40%. So we are a young nation. Naturally, there will be the young MI rates will be higher. This is again another of those. I just want to impress upon you about the reason that this is something which was published very recently, which all showed that we are almost similar. India is almost, of course, we have a special proclivity to develop coronary artery disease. I am not negating that. But if you look at the prevalence rate and the incidence rate, we are almost near similar to the other world. What is concerning, as I said earlier, was the increasing, even though we could reduce the mortality rate. I'm sure cardiologist, physician who is here will agree with me that we see lesser and lesser number of deaths due to an acute STEMI or acute coronary syndrome. It's just considerably during earlier times when I started practice sometime in the late 80s, it was something like 15% or 12%. Now it has come to something similar to the Western statistics, 3.5% or 4%. This is again, look at that. So we have to be concerned about, despite the reducing numbers of CVD deaths over the years, still we have a higher disease burden, we have a higher mortality and morbidity rate. This is the GBD Karnataka data. This is the little busy slide. You can go through the GBD, each state you can get the global burden disease data, and this is something to, but you are much better. Your data is much better than Kerala. Your data is much better than Tamil Nadu. Your is much better than Punjab. But don't be very happy about it. You still also have a problem. We all have a problem. And the projections in South Asia also is again astounding. We are going to have a huge burden. Even though I didn't caution you much about the Indian data initially, but we have a problem, and we are going to see a future ridden with increasing cardiovascular death. Well, there are umpteen number of data happening, newer and newer informations coming. Even Bangalore is one of the epicenter of cardiovascular research in telling us about the genetic makeup, the importance of the maternal, the mastics center from Bangalore, I am told, is doing a fantastic work. Mysore is again doing a fantastic work. So globally, I mean, we are part of active research trying to understand what is the complex interplay of the biological risk and why the Indians are more have a proclivity to develop. Dr. Desai has told me only to talk about the physician perspective. I will not go much into the epidemiologist or the clinical scientist perspective and bore you with a lot of other things, except to say that the factors influence the cardiovascular disease vary from infancy to adult. And we are now trying to understand. Earlier, when we assess a particular patient, somebody comes with diabetes, hypertension, smoking, you try to find out what is the 10-year risk score. That is what we all have been doing. But now the concept is gradually changing to understanding the life course. What is the life course of this particular person who have come, because the CVD doesn't disappear in 10 years. So it is the entire life we have to be understanding about the risk factors and its effect on this particular body. So for the understanding the life course of cardiovascular disease, now we have a very many life course model. I know again this is something a little mundane, but a lot of research is happening in the life course model of cardiovascular disease. But it is true, whatever you say about the life course, we are always talking about the Indians have thin fat babies. Even at the birth of our children, the entire, there is no difference in the between stage there. The Indian phenotype is a little different. We are born with differently. We have more of visceral adiposity, and forget about all those things. You look at the risk factors that we have. Again, recent data. It is basically the metabolic risk factors which is fundamental to the increasing presence of our increasing CAD. I may not have too much of time because these are things that you would have seen many a time. I will just stress on. Again, I just wanted to share with you the NFHS data showing you that we are abundant in risk factors. You look at the number of hypertensive, maybe 270 million. Look at the number of diabetic, maybe 96 million. I mean, it may be an understatement. Pre-diabetes, another 110 million. So we don't need to possibly scout around for reasons, even though it's good to know about the thin fat baby concept, but we have an abundancy of risk factors. And look at the lipid disorders. And every risk factor estimated in Indian subsets are higher. And again, in 2025, there was an article in AJM sometime in June or so. But they found out that if you have 5 risk factors, a man has a 38% chance of developing CAD, and a woman has a maybe 27% chance of developing a risk factors by age of 50 years. And if you have no risk factors by 50 years, you are a fortunate guy, but yet you get a 13% or a 16% man and woman chance of developing coronary artery disease. So it is basically the risk factors, and look at that. The projections of metabolic diseases. This is one of the most important studies that Dr. V. Mohan has done recently, a couple of years ago. And this again opened our eyes. Look at the risk factor prevalence in our country and blame it on that. Blame it on nurture than nature. 1 in 4 Indian, but then look at that. Interestingly, Karnataka doesn't have that. That is very interesting. No? You are fortunate to have less obesity. I don't see any obese guys here. Maybe you are very fortunate in that way. And contribution, each of these risk factors contribution, again, I don't need to stress on you on this importance of how much each risk factor amongst them hypertension being possibly the most important. I was just mentioning you, this was the NEJM article which showed us that if you have 5 risk factors, what will be your chance of developing a coronary artery disease? Amongst all these risk factors, possibly the most important part is hypertension, and unfortunately our awareness, our control rate of, I don't need to tell you how bad we are, even though we have a intensive promotional group nationally to treat better hypertension. Even now the control of hypertension is something less than 30% or 35%. So there are very many strategies of the burden of cardiovascular disease. This is again from the Professor Salim Yusuf group. This is maybe the simplest of the versions that I could see. I'm going to show you a complex version later, but again, I don't need to confuse you further. These are areas where, as practicing physicians, now we don't have much of an information or knowledge, even though I do agree that involving with the pundits of preventive cardiology, we have some knowledge, especially Bangalore and St. John's, and they have been doing wonderful work on that. So these are the major tasks, and these are applicable to, especially to us, the lower middle income and the middle income countries. We are not at 5 trillion, I suppose, so I can still call lower middle income. So these are the simplest ways by which possibly we can decrease the burden of, and each one of them. Even though I will not say polypily, is it a panacea? No, it is not a panacea, but it's not a bad idea, even though it has not caught up. The important thing that is happening is how big data and digital help is going to help us in understanding the disease and possibly going to help us in a substantial way in prevention of cardiovascular disease. Again, time will not permit me to go through these individual items. I mean, the concept of, again, we have been always talking about CAD. The concept is again now changing to now, since the importance of metabolic disease, diabetes, NAFLD, now especially more India-centric. So CKM concept, I think, is very much suited to in the Indian concept. And here again, you could see that how to reduce. Look at the last column. You could see that how to promote the cardiovascular, metabolic, and kidney health. I mean, forget about it. I was mentioning about the life course approach. I just want to also mention about, I mentioned about the importance of vascular disease right from birth to the older age. And a lot of data is being done on that, including Bangalore is doing a fantastic work. And they have included the concept of CKM, and the disease prevention is applicable to the metabolic and kidney health. Earlier, now again, I was talking about when patient comes to us, how to sort of stratify his risk. We have been using more of the pool cohort equation and even the Q-risk score, because we thought the Q-risk scoring is more useful for us, because it has been done in a large number of patients. But the last couple of years has shown that, and this has been validated extensively, the advantage of prevent score over any of the other Framingham or Q-risk or pool cohort equation is that it has included, now it has a base model and it has an extended model. So you can use any of these for calculating a short term, a 10-year risk, and also a 30-year risk. And this is for the first time. I mentioned about now we've been all focused on assessing the 10-year risk of an individual when somebody comes with multiple risk factors. Now the concept has changed. We wanted to know the lifetime risk, which is very difficult right now, but at least with the prevent scoring. And I'm sure all of you know about the prevent score, and lot of data, lot of validation is happening. More than 6 lakhs patients data has been taken into validate the prevent score. And these are the few takeaways. You can use the basic data in a large number of patients. I do agree that we are a low-income country. We will not be able to utilize any fancy biomarkers or fancy imaging technique to assess the score. But even with the base model, we will be able to predict the cardiovascular disease score in a particular person for the next 30 years, and we will be able to help them individually as a physician. I'm not talking about the population science here. Well, there is you can always argue, debate about the usefulness of imaging. Is CT scan going to replace all this risk scoring? I'm not here to talk about that. Maybe we will have it during our lunchtime. We can debate on the importance of what is the role of CT coronary angiography in prevention. But we have, this is something, a telling evidence that now imaging helps in a substantial way, and every cardiology body is talking about the importance of imaging in stratifying the risk. I just want to quote Cochrane here, who said that the practitioner should have a conclusive evidence that screening can alter the natural history of disease in a substantial way. So please remember the great Cochrane's words before you do that. Maybe I will take 5 minutes or more. Couple of minutes. Maybe I will just run through it. Again, this is the AHA's grade 8. All of you are aware of that. The ESC was very insistent on the level of mental health in the prevention of cardiovascular disease. So give importance to stress and the mental health. I was mentioning about this 5-way target earlier. This is a more complex model for individual and society. And here, I think as a physician, we have little to do. We fail because of very many reasons in preventing cardiovascular disease. We mainly fail because our public health systems are not in order. We fail because we spend scanty money for health in our country. We don't even we have only a law to prevent smoking. We don't have any law. And now these things are coming now. The sweet, what is that called? That circle, that has been banned. The sweet thing, the sweet dish, we see it in every cardiology meeting, I think. Right. So the government has to do something about our calorie consumption, our sugar consumption, our food consumption, and we have to also do something for our guidelines. People believe our guidelines. The quality of the Indian guidelines are, I am part of the honor of that. I am also involved in guideline creation, but I said here, quality is pretty bad. So this is something what the vision says. I just wanted to show you some of what we have done in the state of Kerala. I will not have time. I just wanted to show you what we have done, and every state should have their data. This is the time of big data, and you should have, Karnataka should have your own data on everything, on CAD, on your risk factors. That is what we have tried to do. We have now 15 registries going on risk factor prevalences, and we also showed that you can reduce. This is not because of the registry that we reduce the mortality. At the time of Kerala ACS registry, MI mortality was 9.4%. When we did after 9 years, the ACS-Q, the first randomized controlled trial in cardiology in India, the mortality was 3.4%. Not because of registry, but it tells you that we could do much better in very many ways. These are some of the things. I will not. This is again, you decide on what should be your Karnataka's policy on STEMI reperfusion. You find out whether it suits you to do a thrombolysis and later a PCI, elective PCI, or a primary PCI. That is what we did. We tried to find out the accessibility of catheter-based reperfusion and found out that 78% of Keralites can go for a primary PCI. So we don't need a systematic PCI concept. I'm not saying it is bad, but we can find out, and as a cardiologist we can do that. We also found out that young hypertensives have the worst treated guys. 20s, 30s, their hypertension are poorly controlled than adult hypertensives. We even have a Kerala model. Okay, forget about that. Desai told me 4 areas. The present challenges are gross. Okay? Immediate actions are required. As physician, possibly we can do better risk stratification, better advising, and early treatment intervention, and of course on lifestyle modification. Future directions, there's a lot in the offing, and the AI, machine learning are going to help us in a big way. We need a lot of actions, a volley of actions, a multidisciplinary collaboration, absolute interest and involvement in research. This is what Brownwall said a couple of years ago. In 2032, the role of cardiologists will be interpreted to apply genetic information and AI in prevention. And the cardiologists in future will need to do a lot of things, more than what we are doing. Thank you very much for kind attention.
Thank you, Dr. Mohanan. It was extremely good perspective on the prevalence of coronary disease and now cardiovascular, kidney and metabolic diseases. He is rightly praised to give this talk because he has done a very pioneering work in conducting registry data on various aspects of cardiovascular disease in Kerala. It has been a really pioneering effort and is being much talked about, and I think many states have to follow that principle. It also clearly shows that if you have a will, you can do it. You don't have to have large funding or large. I mean, it's an excellent model where all the cardiologists got together and did it as a private enterprise. There's no big funding that was involved. I must congratulate Dr. Mohanan for doing this kind of work and bringing the awareness. I mean, now in every meeting we go, the Kerala model is being discussed, and I think it's a good role model for all of us. And of course, Dr. Prem Payal's group, Dr. Iyengar, many of us in the beginning did this kind of work, and I'm sure this will probably within a decade, I feel, you will see more and more of Indian data being quoted rather than we keep on talking about Framingham study and other studies. With these few words, since we are already a little late, I want to thank Dr. Mohanan for giving this extremely good lecture. Thank you.
May I request the chairpersons and Professor Desai to hand over a memento to Dr. Mohanan. Thank you, sir. That was